Okay, so I'm just gonna film my video opener right now. So I'm just gonna show you that I've got my laptop open right now. And my laptop currently has a video open or discussion points on it. So the first point was to discuss what position the patient should be in and why. So the patient should be in a lateral recumbency position because the patient weighs over 7 kilograms. So we're going to be using the thoracic pump method. So the thoracic pump method, your hands are going to go caudal to the heart of the animal, and this way we're going to have the blood is going to go when you're compressing down. The blood is going to move forward towards the heart and go through the vena cava and the atria, and it's going to get delivered to the rest of the body in that way. So that explains where the compressions are going to be performed on a Labrador Retriever. What is the rate? The rate is going to be 110 compressions per minute. And the depth of recoil and why it's important. So the depth of the recoil is going to be 1/3 to half of the width of the chest. This is really important because we want to make sure that we are getting a big enough depth that we end up having enough movement of blood from the chest and the lungs all the way up to the heart and to be distributed to the rest of the body. It's really important that we actually wait for the recoil of the chest before we do another compression, because this allows the chest cavity as well as the heart to be able to fill with the blood, and then it allows us on our next compression to actually be able to move the maximum amount of blood possible to the rest of the body. So it's super important that we wait for a full recoil, and it's going to give us our optimal chance at ROSC. Next point was discuss what position the patient is in when the cycle intubation is performed. So we should already be doing, if there's more than one person able to perform the CPR, we should already be doing chest compressions while the person is intubating. So you're doing chest compressions first as the lead, and then the person that's doing the intubation while you're doing chest compressions is intubating at the same time as you're doing those compressions. So we're not stopping to intubate. So that patient is going to be, in this case, in a lateral recumbency position. What rate is the patient ventilated? So the patient is ventilated and giving 10 breaths every minute. So basically receiving a breath every 6 seconds, and the breath length is 1 second. And the patient should be bagged. You want to make sure that you're fully compressing the bag and then releasing it. So you for 1 second. So the actual compression of the bag is lasting a second. Then we're giving a few seconds and giving another breath. So we're giving 1 breath cycle every 6 seconds. What are the two key pieces of monitoring equipment should be used, and what is the importance of each? So the two pieces of monitoring equipment that we're using are the ECG, and we're using the capnometer. So we're going to be monitoring the CO2 level, and we're also going to be monitoring the ECG. So the ECG is going to tell us whether or not we do have electrical activity occurring in the heart. It will be able to tell us whether we have pulseless electrical activity, whether there's no electrical activity, or whether there's spontaneous electrical activity. If there's no electrical activity, we're not going to be able to pick up electrical activity to be able to do a defib. If we do have sporadic electrical activity, that's where the defib comes in, and the defib is going to be able to, basically it shocks the myocardiocytes and to a normal rhythm, so it provides an electrical shock to the myocardiocytes that are giving off spontaneous electrical currents, and it actually puts them into the refractory period, so it's making them have a rest, they stop, and then going back into a normal rhythm again. So it's actually, the defib's actually acting on the myocardiocytes, but in order for a defib to work at all, it needs to actually pick up on a electrical current, so spontaneous. current and get it back into a normal rhythm in that regard. And then depending on what we are seeing, whether or not there is electrical activity depends on what drugs we may be giving, and it depends on how we're going to go through the CPR. So it's important to be able to read that, and then to be able to look at the SpO2 monitor. If we're getting over 15 mmHg, we know that we actually are giving a good depth and a good rate of compressions. It's a good indication that we are delivering enough blood throughout the body, and it's a good indication of the way that we are performing our CPR. So we want to be looking for that. And then we're going to discuss how vascular access could be gained, giving 2 options, briefly describe what a cut down is. Okay, so vascular access can be obtained in a couple of ways. Of course, it can just be done by an IV catheter, so that's an option. Alternatively, if an IV catheter isn't available, we can do intra-os. We could be doing a cut down. So how we do a cut down? So we need to actually make a cut at the skin, and to be able to actually take forceps and put the forceps underneath the vein. And if we actually are able to see blood in the vein at that point, once we have the cut, then we're able to place the catheter at that point. If we are, and we were just very similar to what we would do if we were doing an IV catheter, when we didn't do the incision into the skin to actually be able to visualize the vein. But if we could not see blood in the vein at that point, then we make a small incision into the vein, and then from there we would use an automatic catheter, or we would use a bent 22 gauge catheter, and then we would put the catheter in at that point, and then we would use sutures to be in some tape to be able to hold the catheter in place. So the important thing is that you're using mosquito forceps, so it should be a sterile process, and you're not actually grabbing the vein or anything along that line, but you are using mosquito forceps to be able to lift up, so you can actually have access to the vein and kind of segregate it, I guess. So next question here is, if vascular access cannot be obtained, what's an alternative? An alternative is intra-os, and name the drugs and the dose method of administration. So we would have several different drugs that can be administered in this fashion. So the drugs that we can administer in this fashion would include things like epinephrine. We can do vasopressin. There are many options: atropine, sodium bicarb, amlodipine, lidocaine, naloxone, flumazenol, or flumazenol, and natropimazole. So several different drugs that we can administer to do intra-os. So there's that option as well. And then going back, I just want to make sure I answered all of the questions above. Describe what the cut down is. I believe I answered that one. Yes. And then I made a mistake. I was following the formula that we were given through, let me see if I can pull these sheets over here. Through our CPR algorithm, I followed this sheet here. And in following that sheet there, I ended up giving my patient atropine. I thought that's what we were supposed to be doing, instead of vasopressin. And then I read the notes closer for the assignment and realized I was supposed to be giving atropine instead of vasopressin. So I gave vasopressin and thinking that that's what I was supposed to be doing. So I should have been giving atropine, not vasopressin. So I realized that I made a mistake there. But if I was to be giving atropine instead, I would look at my textbook right here, or I actually ended up printing out the sheet that has all the emergency drugs on it, and I put that into our surgery room, so we have that option there now. So I can see here that atropine, it's 0.4 milligrams per kilogram. If we get a 30 kilogram